Money is very tight in healthcare right now. The margins are going down, reimbursement is going down, expenses are continuously going up, and the expectations are going up, as they should. Value-based care to us means that you have to deliver extremely high quality care, but you have to be efficient and give effective care. So you can't do things that are unnecessary. You need to work smart and figure out the best ways to deliver care to the patient that they have the best outcomes, yet without wasting resources and figuring out the best way to do it. And that isn't so easy. In medicine, we've always had the attitude more is better, but more isn't better. Sometimes more is worse. If we look at patients with advanced illness, for example, who are really dying, very often, especially in the New York metropolitan area, they will be seeing large numbers of doctors and receiving, for example, chemotherapy up until the day they die. That may not be appropriate. We'd have to educate the patients to get them to have an informed decision, see what they want to do. And then those resources then could be used for patients who truly could use them. And in the meantime, the patients with advanced illness will get the appropriate care, which in fact there was one study that showed that patients who got comfort care and palliative care with advanced lung cancer actually lived longer than the patients who were getting aggressive care in the last several months. They actually lived 3 months longer. So it's not necessarily a substitute of care. It's not necessarily restricting resources to those patients. They actually do better. That's what's meant by value. It not only produces high quality, but it also the quality of life for the patient. I think the changes the patients will see will be several. One is really the move towards shared decision making. They need to be informed about the various possible treatments and why one may be better than the other and what will result for them in better function and quality of life. Sometimes we all concentrate on measuring things which sound good on paper, but they're not that important to the patient. So a patient who goes in for a joint replacement doesn't think they're going to get an infection, doesn't think the prosthesis is going to fail. They expect those two things will not happen. Their expectation is, how soon can I go back to work? How soon can I go play golf? How soon can I go play with my grandchildren? Those are the things that are important to patients. And we need to bring that to medicine and get the patients to really say, that's what I want, so we can concentrate on the things that are important to patients beyond just the usual things that we always think about scientifically. Having a fully integrated system makes it much easier, and that's partly economies of scale, that you can use resources and spread them widely. I think the biggest thing about an integrated system is that we have all the pieces in place. So we have the acute care hospitals, the ambulatory sites where patients get seen. Now we've gone on to joint ventures with urgent care centers, so there's access on off hours. In addition, we have home care, home infusion, as well as several rehab and long-term care facilities. So we have control of the whole situation and can make sure that the patient arrives and is cared for at each of those sites of care, and at the same time that the care is coordinated between them. And that's a very important thing. The trouble for hospitals that don't really integrate, or even standalone hospitals, is they might be able to do some of this on a small scale, but that really doesn't work for larger communities. And people today don't stay in one place. They travel. They may not, they want to go for wherever they're going to see the best care. And therefore, just because the hospitals in their neighborhood may not be where they go, and that may affect smaller hospitals. Also, the other advantage of an integrated system is we really pull out the best from all the different hospitals. So it could be one of our small community hospitals comes up with a great program that really is good for continuity of care, transition of care, and we'll apply that all over, including our tertiary and quaternary hospitals. So it's not always that the big hospitals have the best ideas or the best procedures or the best ways of processes. We will learn from each other and then spread it and test it, understanding that there are still community differences, and you have to be sensitive to them. You also have to be sensitive to the fact that even the smaller hospitals don't always have the same resources as larger hospitals. So you have to modify things, but it allows you to standardize things and learn from each other. One of our smaller hospitals came up with a great idea of transition of care, of actually using a commercial product and partnering with their primary physicians in the area, and they make an appointment when the patient comes to the emergency room within 48 hours or within 2 business days if it's over a weekend, for the patient to see back to their doctor with the information available electronically. And for patients, it's no longer, well, I got seen in the emergency room on Saturday, I'll leave a message on the answering service on Sunday, and maybe on Monday or Tuesday they'll call me back and I'll be able to get an appointment before the end of the week. If they need follow-up early in the week, when they go home on Saturday, they already have that appointment scheduled so that they can go see the doctor on Monday. That's the type of idea that the small hospital piloted. Another one of our hospitals came up with an idea of working with a company to develop pads for that, really like an iPad, for each of the patients when they're in their room. That gives them the opportunity not only to look at their lab tests, which is really important in today's day and age to get the patients engaged, lets them change the TV stations and go on the internet, but also has a large amount of educational material for the patients. So the patients can understand if they're going down for an MRI, they can hit an application and it'll be a little video telling them what an MRI is like, what they can expect, what happens when they go down there. And that makes a real difference for patients in terms of they're not scared, they understand the process, and when they understand the process, they tend to be much more compliant also, and that helps us erode the compliance issue. I think value-based care is starting to have an impact on the bottom line, certainly with Medicare, when they lowered rates and we took a hit on some hospitals on hospital-acquired conditions. The data may have been 2 or 3 years old, but it is what it is, and that took a hit. So it is having an effect. I think what value-based care will have is an increasing effect over time as more money is at risk. What you will see is insurance companies, instead of saying, well, this is the rate we're going to give you, and next year we'll raise it a little bit for cost of living and this year, they're going to say, all right, we're going to give you this rate, but 20% of it is dependent on performance. 80% is guaranteed, but you're at risk for the 20% depending on how you do. That will mean that health systems and hospitals that don't perform well in value-based purchasing will actually take a hit. And that is, you have to be careful because much like Medicare, you don't want places that are already struggling to have less money available to care for patients. It costs money to put these new methodologies into place. It costs money to measure how you're doing. And then it costs money to try and get the physicians online and work with them. That's all expensive. And if you take away more money, it becomes harder to do. But we have to do it.